Welcome to ClinMed Compass, your path to medical excellence. Today, I will be guiding you through a comprehensive lecture on peptic ulcer disease, simplified for clarity and deeper understanding. I am Dr. Kevin, and I will be your host. If you haven't subscribed to our channel yet, please do so, and don't forget to tap the notification bell to stay updated on all our new videos. So, grab a notepad and let us dive into the fascinating world of peptic ulcer disease made easy. By the end of this session, you should be able to define peptic ulcer disease, identify its major etiological agents, understand the pathogenesis, outline the diagnostic strategies, and discuss treatment options, as well as recognizing key complications. What is peptic ulcer disease? Peptic ulcer disease refers to the focal loss of epithelial lining in parts of the gastrointestinal tract, typically in the stomach or the duodenum, due to the destructive action of acid and pepsin. What differentiates an ulcer from an erosion is the depth of the tissue damage. Ulcers penetrate the muscularis mucosa and often lead to scarring. Erosions, on the other hand, are confined above the muscularis mucosae and do not scar. Peptic ulcer disease is considered a chronic disorder characterized by frequent exacerbation and remissions. The commonest site of peptic ulcer disease is the stomach and the duodenum. Other sites include esophagus, the gastrointestinal anastomosis, ectopic gastric tissue as in Merkel's diverticulum, and even in the jejunum in cases of Zollinger-Ellison syndrome.
Briefly, we will discuss the epidemiology of peptic ulcer disease.
It affects between 5 to 10% of the global population. Encouragingly, the global burden is reducing, largely due to effective eradication of Helicobacter pylori, improved sanitation, and widespread use of proton pump inhibitors. However, in developing countries, peptic ulcer disease remains a significant challenge due to ongoing issues with poor sanitation and inadequate treatment of Helicobacter pylori infections. Poor hygiene and overcrowding increase Helicobacter pylori transmission. PUD is said to be more prevalent in men than women. Peptic ulcer disease is most common among middle-aged and older adults, with a peak incidence between the ages of 25 to 60 years. Among the two major types, duodenal ulcers are more frequent than gastric ulcers. In tropical regions like Nigeria, while large-scale field prevalence data is limited, hospital-based endoscopic studies in dyspeptic patients show that PUD is diagnosed in as many as 20 to 40% of cases. This underscores the high burden of undiagnosed or mismanaged dyspepsia in clinical settings. Now, let us explore the major causes of peptic ulcer disease. One is Helicobacter pylori infection. This is the most important cause. Use of ulcerogenic medications like NSAIDs and corticosteroids, hypersecretory states such as Zollinger-Ellison syndrome, genetic predisposition, lifestyle factors such as smoking, alcohol, coffee, and chronic stress, viral infections like cytomegalovirus infections, herpes simplex virus 1, particularly in immunocompromised individuals. Let's look at more details on Helicobacter pylori, for short H. pylori. H. pylori was first identified in 1983 by Warren and Marshall, whose groundbreaking discovery earned them the 2005 Nobel Prize in Physiology on Medicine. It was initially called Campylobacter pylorides. Today, it is recognized as the most common bacterial infection worldwide. In developing countries, 80 to 90% of individuals are infected by age 20, while in developed countries, prevalence is less than 20% under the age of 20,
rising to 50 to 69% by the age of 70.
In developing countries, most children acquire H. pylori between the ages of 5 and 10 years. Key risk factors include low socioeconomic status, poor hygiene, and overcrowded living conditions. Transmission is by fecal-oral and oral-oral routes, occasionally through iatrogenic means. Beyond PUD, H. pylori is also associated with gastritis, gastric adenocarcinoma, and gastric mold lymphoma. It accounts for 70% of gastric ulcers and 95% of duodenal ulcers. Now, let's examine the biological features of Helicobacter pylori. It is a gram-negative, spiral-shaped microaerophilic bacillus. It is slow-growing and highly motile due to multiple flagella. It produces urease, enabling it to neutralize gastric acid and create an alkaline environment. It can transform into a coccoid form in its dormant state. This facilitates its survival in adverse conditions. It causes mucosal injury through chronic inflammation and urease activity, which weakens the stomach's protective barrier. This is a visual of Helicobacter pylori, the multiple flagella spiral-shaped organism. Now let's shift our focus to the second major cause of peptic ulcer disease, NSAIDs and related medications. Drugs like aspirin, ibuprofen, and even corticosteroids compromise mucosal defenses by inhibiting prostaglandin synthesis. Other implicated drug classes include the selective serotonin reuptake inhibitors, tricyclic antidepressants, and bisphosphonates. NSAIDs are responsible for about 30% of gastric ulcers and a smaller proportion of duodenal ulcers. They are currently the leading cause of mucosal injury in the Western world. NSAID-induced injuries ranges from superficial erosions to ulcers and to gastrointestinal bleeding. Even patients on low-dose aspirin for cardiovascular protection can experience gastrointestinal toxicity. The severity is often dose-dependent. Now let's look at some less common causes of peptic ulcer disease. Hypersecretory states like Zollinger-Ellison syndrome, which involves a gastrin-producing tumor, gastrinoma, leading to excess acid production. Systemic mastocytosis and antral G cell hyperplasia can also drive increased acid production. Genetic predisposition. Identical twins show 56% concordance rate. First-degree relatives have a threefold increased risk. Individuals with blood group O are more susceptible. Smoking is a key modifiable risk factor. It contributes to peptic ulcer disease by increasing gastric acid secretion, decreasing mucosal blood flow, reducing protective prostaglandins, inhibiting duodenal bicarbonate secretion, enhancing H. pylori virulence, and delaying ulcer healing. Alcohol has several harmful effects on the gastric mucosa. It causes direct mucosal injury, leading to erosions and irritations. It increases acid secretion, decreases mucosal and bicarbonate production, and when it's combined with NSAID, it significantly increases the risk of ulcer formation. Another contributor to peptic ulcer disease is stress, both emotional and physiological. While stress may not directly cause ulcers in healthy individuals, it plays a significant role in hospitalized or critically ill patients. Two specific types of ulcers include the Cushing's ulcers, which is associated with brain injuries or tumors, the Collins ulcers, which is seen in patients with extensive burns, In cases of sepsis, hypotension, or multi-trauma, mucosal ischemia impairs gastric defenses, making the stomach lining more vulnerable to acid damage.
Let's take a closer look at the gastric secretory complex.
In the antrum, the mucous neck cells secrete mucus and bicarbonates. The G cells produce gastrin, a hormone that stimulates acid secretion. The D cells secrete somatostatin, which inhibits gastrin release and provides a negative feedback. In the fundus and the body of the stomach, we find oxyntic glands, which contains the parietal cells, which secrete hydrochloric acid, and the chief cells that secrete pepsinogen, which is converted to pepsin in acidic environment to aid protein digestion. The stomach isn't defenseless. It has several protective mechanisms to prevent self-digestion by acid. One of them is the mucous bicarbonate barrier. This forms a gel-like layer that neutralizes acid at the mucosal surface. We have the prostaglandins. They stimulate mucus and bicarbonate secretion, enhance mucosal blood flow, and promote epithelial cell repair. Then the tight junctions will prevent back diffusion of hydrogen ions into the mucosa. Other protective mechanisms include the mucosal blood flow, which supplies oxygen and nutrients and help clears acid and toxin. Then epithelial cell turnover. This enables rapid regeneration of damaged cells. This delicate balance between injury and repair is essential for maintaining mucosal integrity. Even with the protective mechanism in the stomach, several aggressive factors threaten mucosal integrity. One is the gastric acid. This is secreted by parietal cells and stimulated by gastrin, histamine, and acetylcholine. Pepsin. This is activated in low pH. It digests protein but can also damage mucosal tissues. Then the bile salts. Reflux from the duodenum and highly irritating to gastric epithelium. Next is the Helicobacter pylori, salicylate, and alcohol, all capable of inflicting direct mucosal damage. Having discussed the protective and aggressive factors, it is important to state that ulcers will develop when there is an imbalance between the aggressive and protective factors. When damaging forces outweigh the mucosal defenses, ulcers will definitely develop. This concept is useful, but it cannot explain the basis of peptic ulcer disease in totality. Let us look at the role of Helicobacter pylori in the pathogenesis of peptic ulcer disease. Helicobacter pylori is a master at evading defenses and promoting injury. It colonizes the mucous layer and disrupts the mucous bicarbonate barrier. It also stimulates gastric acid secretion. It produces urease, which converts urea to ammonia, damaging cells and neutralizing acid, aiding its survival. It reduces proteases, and this contributes to mucosal degradation. H. pylori exerts direct cytopathic effects also on the gastrointestinal mucosa. And it gets worse. Helicobacter pylori also reduces bicarbonate secretion in the duodenum. It induces inflammation by activating neutrophils and macrophages and releasing cytokines like interleukin 8 and reactive oxygen species. It also disrupts tight junctions, thereby increasing acid back diffusion, and stimulates gastrin release, which further increases acid output. Now, let us look at the role of non-steroidal anti-inflammatory drugs in the pathogenesis of peptic ulcer disease. NSAIDs disrupt mucosal integrity through multiple mechanisms. One, it inhibits cyclooxygenase 1 enzyme, leading to reduced prostaglandin synthesis. Decreased prostaglandin results in reduced mucus and bicarbonate secretion, impaired blood flow, and delayed healing. NSAID also cause direct epithelial toxicity, and increased gastric acid secretion, contributing to ulcer formation. Besides Helicobacter pylori and NSAIDs, other contributing factors include smoking. This reduces mucosal blood flow and delays healing. Alcohol stimulates acid secretion and irritates the mucosa. Stress, especially in critically ill patients, impairs perfusion and suppresses protective secretions. Zolliger-Ellison syndrome, a hypersecretory state, it's a gastrin-secreting tumor causing profound acid hypersecretion. Let us look at the clinical manifestations. The cardinal symptom of peptic ulcer disease is abdominal pain. It is typically epigastric, burning, gnawing, or described as peppery in character. The pain is episodic and may radiate to the back, especially if the ulcer penetrates the pancreas. It is worse at night and may disturb sleep. The timing of the pain helps differentiate ulcer types. In duodenal ulcers, pain occurs 2 to 3 hours after meals and is relieved by food or antacids. In gastric ulcers, pain worsens with meals due to acid secretion. Beyond pain, patients may also experience nausea and vomiting due to irritation of the gastric mucosa, bloating and belching, especially if coexisting functional dyspepsia is present. Weight loss, which is more common in gastric ulcer, especially if eating worsens symptoms or if the ulcer is malignant. Not all cases of PUD present classically. Some patients have non-ulcer dyspepsia, which is ulcer-like symptoms without visible mucosal breaks. Elderly patients and those on NSAIDs may present with silent ulcers, diagnosed only when complications occur. These atypical presentations are dangerous as they delay diagnosis and treatment. Let us examine duodenal ulcers in more detail. Duodenal ulcers commonly affect adults aged 25 to 75 years with a male predominance. About 90 to 95% of duodenal ulcers are linked to Helicobacter pylori infection. Other risk factors are smoking, NSAID use, and family history. About 90% of duodenal ulcers occur in the first part of the duodenum, usually within 3 centimeters of the pylorus. Duodenal ulcers present with epigastric pain, which could be burning or peppery, often within 2 to 3 hours after meals or at night. The pain is typically relieved by food or antacid. Weight loss and anorexia are uncommon. For gastric ulcers, the peak incidence is between 55 to 65 years. Common causes include Helicobacter pylori, non-steroidal anti-inflammatory drugs, especially when combined with corticosteroids. It presents with abdominal pain. The pain occurs shortly after meals and is less relieved by food or antacid. Eating may trigger or worsen the pain. 1/3 of patients experience nighttime symptoms. Weight loss and anorexia are more common than in duodenal ulcers. Treatment typically requires a longer duration to ensure full healing. Now let us review the red flags, which we refer to as the alarm symptoms. These may indicate complications or malignancy. The first is new onset symptoms, especially in patients above 45 years. Anemia, which could be iron deficiency, significant weight loss, recurrent vomiting, melena or hematemesis, and dysphagia. These symptoms warrant urgent endoscopy to rule out cancer or bleeding ulcers. Peptic ulcer disease can lead to serious complications, the most common being gastrointestinal bleeding. These patients will present with hematemesis, melena, iron deficiency anemia from chronic blood loss, hypovolemic shock in cases of massive hemorrhage. Bleeding ulcers are a major cause of upper GI emergencies. Another life-threatening complication is perforation. especially with anterior ulcers. They present as sudden severe abdominal pain, signs of peritonitis including guarding and rebound tenderness. Imaging may reveal free air under the diaphragm on upright abdominal or chest x-ray. Next is penetration. Penetration occurs when the ulcers erode into nearby organs like the pancreas, leading to persistent or referred pain. Peptic ulcer disease may also cause gastric outlet obstruction due to fibrotic scarring, edema, active inflammation near the pyloric channel. They may present with early satiety, recurrent vomiting of undigested food, abdominal distension, visible peristalsis, weight loss, and dehydration. These signs suggest mechanical obstruction, often requiring intervention. Although rare, malignant transformation is a serious concern with gastric ulcers. Because of this, an endoscopic biopsy is essential for any suspicious ulcer. Even ulcers that appear benign should be re-evaluated with repeat endoscopy after 6 to 8 weeks to confirm healing and exclude cancers. When a patient presents with epigastric pain or dyspepsia, it is essential to consider other potential causes beyond peptic ulcer disease. This includes gastric cancer. Look for irregular ulcer margins, nodularities, or masses on endoscopy. Pancreatic cancer often presents with weight loss and sometimes back pain. Pancreatitis often presents with back pain and elevated amylase or lipase. Cholecystitis, especially when the right upper quadrant pain is present. Gastroesophageal reflux disease marked by heartburn and regurgitation without ulceration. Mesenteric ischemia presents with pain out of proportion to examination findings. Functional dyspepsia, epigastric discomfort with no identifiable organic cause. Biliary colic and gastritis. These are some of the differential diagnoses of peptic ulcer disease. The diagnostic process begins with a detailed history and physical examination. Important questions to ask include the nature and the timing of pain. Is it burning or gnawing? Relationship to meals. Does food relieve or worsen it? Medication history, especially NSAIDs and aspirin use. Lifestyle factors such as smoking and alcohol intake. Red flag symptoms, which include unexplained weight loss, persistent vomiting, dysphagia, or signs of anemia. A thorough history often points towards the likely diagnosis before any testing is done. Let us look at some diagnostic tests in the evaluation of peptic ulcer disease. The gold standard for diagnosing peptic ulcer disease is upper gastrointestinal endoscopy, also known as esophagogastroduodenoscopy. Why choose endoscopy? It allows direct visualization of ulcers. It enables biopsy to assess for malignancy or Helicobacter pylori. It has a diagnostic accuracy of up to 95%. The key findings of note include ulcer sizes, location, and margins. Irregularity or nodularity may suggest malignancy. Biopsy results help guide prognosis and treatment. These are endoscopic images revealing ulcers. During endoscopy, classic findings include round or oval ulcers. The surrounding area can be inflamed, and sometimes you get active bleeding as indicated in one of the images. Biopsy specimens are often taken for histology or rapid urease testing to detect Helicobacter pylori. If endoscopy isn't available or feasible, a barium meal study can be an alternative. It detects ulcer in about 80% of cases. Ulcers appear as well-defined ulcer craters or niches or filling defects in the gastric or duodenal wall. However, barium meal has some limitations. They poorly detect fundal ulcers. They do not allow for biopsy. Up to 41% of gastric ulcers that appear benign radiologically may be malignant on biopsy. So, while useful, barium studies are not substitutes for endoscopy. These are barium meal study imaging, one for gastric outlet obstruction. Look at the arrow indicating the narrowing, and the second is for duodenal ulcers, revealing the ulcer crater. Diagnosis of Helicobacter pylori. Identifying Helicobacter pylori infection is critical in managing peptic ulcer disease. There are two main categories of diagnostic tests. One, the non-invasive test, and the second, the invasive, which requires endoscopy. We are going to explore both tests. First, the non-invasive. The urea breath test is the most accurate non-invasive test for detecting active Helicobacter pylori infection. It is highly sensitive and specific. How does it work? The patient swallows urea labeled with carbon 13 or carbon 14. H. pylori's urease enzyme breaks it down into carbon dioxide, which is measured in the breath. Advantages of urea breath tests. One, it is highly sensitive and specific. It is ideal for both initial diagnosis and post-treatment confirmation. Note that recent antibiotic use or the use of PPI can lead to false negative results. Other non-invasive tests include H. pylori serology. This detects immunoglobulin G or immunoglobulin A antibodies against Helicobacter pylori. The limitation here is it cannot distinguish between active and past infection. Next is the stool or the fecal antigen test. This detects bacterial antigen in feces using immunoassay or polymerase chain reaction. It is useful for both initial diagnosis and post-treatment confirmation. Now let us look at the invasive testing. One is the rapid urease test. With endoscopy, we can perform a rapid urease test, also called the CLO test. How does it work? A gastric biopsy is placed in a medium containing urea and a pH indicator. If H. pylori is present, urease breaks down the urea into ammonia. This raises the pH and changes the color of the medium from orange or yellow to pink or red. This is simple, fast, and a reliable diagnostic tool. Additional invasive tests include culture. It is time-consuming but remains the gold standard for antibiotic sensitivity testing. Next is histology. Allows direct visualization of Helicobacter pylori using special stains like the hematoxylin and eosin or the Wathin-Starry stain. Advanced tools include polymerase chain reaction and DNA probes on biopsy samples, urinary excretion of nitrogen-15 labeled ammonia. These techniques not only confirm presence but also help to assess strain type and antibiotic resistance. Other tests that can be done include the abdominal ultrasound or CT scan, the serum gastrin level in cases of Zollinger-Ellison syndrome, stool tests to detect for occurred blood. Laboratory tests will include complete blood count, anemia, especially iron deficiency or inacute blood loss, liver function tests to rule out hepatobiliary causes of epigastric pain, coagulation profile. This helps you to assess bleeding risk. When should we test for and treat Helicobacter pylori? Some of the established indications include active peptic ulcer disease, history of peptic ulcer disease without prior eradication of Helicobacter pylori, gastric mouth lymphoma, especially low grade, after resection of early gastric cancer to prevent recurrence, uninvestigated dyspepsia, especially in high prevalence setting. In these situations, accurate diagnosis and treatment are essential. Some indications remain controversial. The benefit of treatment may be less clear in the following conditions: non-ulcer dyspepsia, in gastroesophageal reflux disease, in chronic NSAID users, unexplained iron deficiency anemia, and populations at risk of gastric cancer. In these cases, testing and treatment decisions should be individualized based on clinical context and regional guidelines. Treatment of peptic ulcer disease. Let us now summarize the key goals of treating peptic ulcer disease. 1. To relieve symptoms. 2. Eradicate Helicobacter pylori when present. 3 is to promote complete ulcer healing. 4 is to prevent recurrence. And 5 is to avoid complications such as bleeding, perforation, or obstruction. These goals guide our approach to both medication and lifestyle management. Now we'll discuss medications used for symptom relief. One is proton pump inhibitor. They irreversibly block the hydrogen potassium ATPase pump in the parietal cells. Examples are rabeprazole, omeprazole, esomeprazole. Second is the histamine receptor antagonist. These ones block histamine-stimulated acid secretions. Example is famotidine, cimetidine, ranitidine, and others in the class. We have the antacids, which are very popular. They neutralize existing gastric acid secretion. They could be aluminum-based or magnesium-based. Some of them contain other compounds like simeticone and others. Examples are aluminum hydroxide, magnesium hydroxide, calcium carbonate, sodium bicarbonate. We also have the cytoprotective agents like prostaglandin analogs. Example is the misoprostol. This is a synthetic prostaglandin E1 analog that enhances mucosal protection. And we have coating agents like sucralfate. Sucralfate forms a protective gel-like barrier over the ulcer site. Then bismuth compounds, which could either be bismuth subcitrate or subsalicylate. They coat ulcers and have mild antibacterial and anti-inflammatory properties. Other symptom relief agents that have been used previously are anti-muscarinic agents such as pirenzepine. Now we'll talk about the eradication of Helicobacter pylori. Eradicating Helicobacter pylori is key to healing ulcers and preventing recurrence, especially in non-NSAID induced ulcers. A 14-day regimen are preferred over shorter durations. Maintenance therapy is advised in patients with complicated ulcers such as bleeding or perforation. So we'll talk about the first line therapy for Helicobacter pylori eradication. We have the triple regimen. This is use of a proton pump inhibitor such as rabeprazole, omeprazole, and others with either two of these three antibiotics: clarithromycin, amoxicillin, or metronidazole. The duration for treatment is 10 to 14 days and eradication rate is up to 70 to 85%. Failure of the triple regimen can make us use the quadruple regimen. This is actually preferred in areas of high clarithromycin resistance or when there is treatment failure. Here we use proton pump inhibitor plus bismuth, metronidazole, and tetracycline, all for 10 to 14 days. Eradication rate in this case is up to 93%. For patients who failed the first line therapy, you consider the second line therapy, and this includes levofloxacin based regimen where you combine a PPI, levofloxacin, and amoxicillin for 10 to 14 days. Could also be rifabutin based, which we use a PPI, rifabutin, and amoxicillin for about 10 days to 14 days too. or a furazolidine-based therapy where you use a PPI, furazolidine, and amoxicillin for same duration. We should tailor therapy based on local resistance pattern and prior antibiotic exposure. Then we have the sequential therapy where we use PPI and amoxicillin for 5 to 7 days, followed by PPI, clarithromycin, tinidazole or metronidazole for 5 to 7 days. Then we have the concomitant therapy where all 4 drugs, the PPI, amoxicillin, clarithromycin, metronidazole or tinidazole, we use them for 10 days. These regimens are especially useful in high resistance area. Surgery is rarely first line, but it becomes essential in perforation, refractory ulcers, uncontrolled bleeding, gastric outlet obstruction, suspected malignancy, or any complication unresponsive to medical therapy. Surgical procedures include vagotomy, pyloroplasty, gastrectomy, antrectomy, and oversewing of perforation. General measures include important lifestyle modifications such as avoiding NSAIDs, aspirin, corticosteroids unless they are necessary, limiting alcohol and caffeine use, stop smoking, educating patients on medication adherence, and encourage stress reduction and psychological support. Briefly on managing complications. For bleeding, endoscopic hemostasis, blood transfusion if needed. For perforation, emergency surgery like the use of Ometa patch. For gastric outlet obstruction, endoscopic dilation or surgical resection. Early recognition and intervention are critical. Few words on peptic ulcer disease and diet. Let us bust some of the myths. Drink milk to soothe ulcers. This is false because milk stimulates acid. Avoid all forms of spices. This has no solid evidence. Don't eat fried foods. Even though greasy food may worsen symptoms, but they don't cause ulcers. Current evidence suggests that stress, spicy food, they are actually insignificant risk. Frequent ingestion of milk, like we said initially, is associated with increased acid production. Prevention is key. Test and treat H. pylori in all ulcer patients. Confirm eradication of Helicobacter pylori after 4 to 6 weeks using the stool antigen test and urea breath test. Serological tests are not reliable post-treatment. Post-eradication follow-up is important. Repeat endoscopy at 6 to 8 weeks for gastric ulcer. Long-term use of PPI may be needed in chronic NSAID users, elderly, and patients with previous complications. Lifestyle modification, as previously stated, no smoking, alcohol reduction, and stress management are important. Key takeaway from this presentation: peptic ulcer disease results from an imbalance between mucosal defenses and aggressive factors. Helicobacter pylori and NSAIDs are the main causes of peptic ulcer. Alarm symptoms warrant prompt endoscopy. Eradication of Helicobacter pylori is critical for cure. Complications such as bleeding and perforation are life-threatening. Follow-up is crucial for gastric ulcers and recurrent disease. Thank you for watching. I hope this strengthened your clinical grasp of peptic ulcer disease. If this was helpful, like this video, subscribe to ClinMed Compass, share with your colleagues, comment below with your thoughts or topic requests. We simplify internal medicine one lecture at a time. I am Dr. Kevin. Stay focused, keep learning, and always follow your compass to clinical excellence. See you in the next video.